Okay, well, good morning, everyone, and thank you for coming to the Women's Health Fair in 2025. This is a really special event for our hospital. We get to showcase some of our medical care and the teams that are happy to work with you and guide you through your health conditions, and also a lot of vendors. It's kind of a pseudo crafts fair, but it's also, there is some medical stuff thrown in there. I would really encourage you to kind of talk to the different vendors and get their information, their pamphlets, their websites, because a lot of these individuals are not only small businesses in St. John, but around the community, but they also are very engaged in their own areas. And to get involved with them and to work with them really helps our overall community, and that's our goal. Our goal, Morgan and I are the cardiovascular team here at the hospital, and we have offices here at the hospital as well as in Bloomsdale. I'm in Bloomsdale on Wednesdays and here the rest of the week, and Morgan is basically here with us in the beginning of the week, and she sees primary care patients out at Bloomsdale at the end of the week. That's kind of how we broke up our schedule. That's fluid, it might change, but overall, people can be seen definitely within a week, but usually within a day or two. If you go into your OBGYN or you go to see Dr. Cavins or Dr. Ware or Dr. Charlo, you need a procedure, they call us up and we get you seen quickly. We don't have month-long waits, 2-week waits, and our job is customer service with high-quality medicine, and that's what we pride ourselves on. I think that's really an advantage of our hospital. We're able to provide the best quality care with the facilities we have here and the opportunities we have here, but we're able to individualize your plans, your care plans in the different aspects of your medical conditions. And today, Morgan and I are gonna focus on the cardiovascular system, the heart system, why it's important, particularly in women, but also why it's important to be proactive about your evaluation and treatment, because our goal is prevention. Our goal is to keep you out of the hospital, keep you out of the operating room. Sometimes we need that, but we want to prevent those things from happening. So thanks a lot for coming. Mary, can you get the lights, or at least the back lights, or front lights? So those of you who know me, you know that art is a big aspect of our life. And art and creation are really important to me. And also, you know, the thought is I want to discuss about the art and the science of individual patient care. And that's really how we focus our practice. Next slide. So as you know, an artist kind of gets everything together. They have their palette, they have the paints they generally use, and then they think about what their subject is going to be, and then they get started. Next slide. So this is a friend of ours, a very famous painter by the name of Simon Bull from England, and hopefully you'll see at the beginning he has an idea in his head, but his goal is to get the picture completed and to show a story. So we start from a blank canvas, just like we start with a blank canvas when you come into our office, and we put it all together, and then we hopefully get a beautiful painting at the end that you can cherish, which is your health and the health of your family throughout the years. So what I'm going to focus on today is who should be screened, who needs testing, when should you have screening, what is the appropriate screening and testing to do, and how often should you do it. I throw a couple cartoons in here to be funny, but a lot of these cartoons really are very relevant. So this is something that comes up a lot. Okay, doc, give it to me straight. How long do I have to ignore your advice? Well, you'll see the answer is kind of, you shouldn't ignore our advice, but the issue is timing is everything. Keep it there for a second. And this other one, which is very important to all of us in this day and age, is give it to me straight, doc, I can take it. Is this going to be covered by my insurance? Okay? And that's really important. It sounds funny and flippant, but it's very important. So our team really works hard with you and your insurance to get the testing completed in a timely manner of what needs to be done in your case. And a lot of times, Morgan and I are writing letters, we're having phone calls with the medical teams at the different insurance companies because we very strongly believe that certain tests or lab tests or x-rays or stress tests need to be completed. And it's helpful for us when we talk to these doctors about what documentation we need in our chart. So it's a learning experience for us. In every case, we always learn something. And our goal is to get the procedures done that you need to come up with a plan that's individualized for you and to keep you healthy over the years. Next slide. So why is this particularly important in women? There's a couple really important factors that I wanted to emphasize. First of all, women are the largest group with coronary artery disease or heart disease that are underdiagnosed and undertreated. Even though, as you'll see, they have the highest risk, you have the highest risk for heart disease. And there's a lot of reasons for that. There's psychosocial, there's environmental, there's bias in the medical community, and also it comes from individuals, how you've been thought over the years, as you guys are the providers for your family. So a lot of people perceive their role as, my job is to take care of everybody else, but what about you? As we say in our family and other families, if mom is not happy, nobody else is happy. So you need to take care of yourself, right? Right. If you take care of yourself and make yourself strong, then it allows you to empower your family to get their health care done. One of the most common things we see, a middle-aged man comes into our office, and the first question we ask is, hi, I'm Dr. Bosner, I'm working Ritter, how can I help you? How did you get here? 50% of the time is my wife sent me, okay? And that's true, but that's important. And that tells us why women are not only responsible for the health care of their family and the community, but you also got to empower that for yourself, okay? We want to focus on increased awareness, which is part of what this talk is about cardiovascular disease in women. We want to discuss with you what kind of diagnosis we can make, get you to the appropriate places if necessary, and develop an individualized treatment plan to keep you happy and healthy through the years. Now, one thing that's important is to look at a little bit of data. Every 30 seconds, a man or a woman dies from cardiovascular disease, a heart attack or stroke in the United States. That's about 2,500 to 3,000 deaths a minute. So our goal is to decrease that. It's never going to come down to zero, but our goal is, with awareness, we can get to the hospital or get to your provider in a timely manner to institute a treatment plan to improve your outcomes. Next slide. So this is showing the importance of the causes of death in women. As you can see, about 375 women out of every 1,000 deaths are from heart disease. If we look at the causes of death, heart disease far outweighs and outnumbers the other causes, which is cerebral vascular disease or stroke, lung cancer, emphysema, infectious causes, breast cancer, accidents, diabetes, and gynecological cancers. So what are the differences? Why is it so important? And why do we see that heart disease is so relevant in women? Well, first of all, there are physical and physiological differences. There's differences in your body, how your body responds to medicines, how our bodies respond to aging, and that's different between men and women. But the excessive mortality in women is likely due to factors other than just physical differences. And what we see is that smoking is common and much more common in middle-aged and younger women than it is in younger age or men. So smoking is a really important factor. And that's something we really focus on as one possible contributing factor. And the other issue is lack of awareness of what ischemic symptoms are. When your body is feeling a certain way, how do you know that it's a heart-related problem, or is it something not to worry about? Next slide. Okay, so what are the warning signs of a heart attack? Of course, chest pain, chest pressure, squeezing pain, and we see that in men and women, but women experience other symptoms more commonly than we see in men. That could be unusual aching in your shoulders or your neck, shortness of breath with activity. You can't do as much as you used to do a couple months ago. And you forget about like cold weather and this and that, just normal household activities. Walking up and down from your basement to do your laundry, carrying your bags in from the grocery store. You have to stop and take a couple breaths. now that you didn't have to do 6 months or a year ago. That could be a sign that something is creeping up. Nausea, vomiting is actually seen in about 1/3 to 1/2 women who present with heart problems. Unusual or unexplained fatigue, a very common symptom. Doc, I'm tired. I can't do what I used to do. So we do an assessment for that, which includes evaluating for heart issues, but also other issues. A very common thing you've probably heard about is sleep apnea. If people don't have a good night's sleep, you can't function better the next day. You get tired, weak, dizzy, and you just don't feel well. So we focus a lot on global care, including doing what we call sleep studies to see if we can assist in your abnormal sleep. And it's not just snoring and stopping breathing. There's a lot of disordered sleeping conditions that we can diagnose and help you treat with your primary care providers. Lightheadedness with activity. If any of these symptoms occur, okay, it's really important to sit down and rest. Take a full aspirin, either a full 325 milligram aspirin, so you should keep it in your purse, a small little bottle, and a bottle in your medicine cabinet at home, or 4 of what we call baby or 81 milligram aspirins. That's what we use chronically for our treatment, and Morgan and I will discuss those treatments, but 4 81 milligrams is 324 milligrams, which is close enough for government work to what a full bare aspirin is. So just take that, and you'll see why that's important. It thins out the blood acutely and will decrease the progression if you are having a heart attack or a stroke. And then call 911 and come to the emergency room. And this, I think, is a really important slide. Only about 53% of women say that they would call 911 if experiencing these symptoms. However, 80% say they would call if their husband or someone else was having these symptoms, right? So we're great at recognizing it, but we don't empower it for ourselves, and that's really important. And for themselves, 46% of the women in the survey would do something than other calling 911, such as they'll take an aspirin, they'll eventually get to the hospital, but there's a big delay. And delay is really important if you're having a heart attack or stroke, because we call that a time-critical diagnosis. This is a study that I participated in when I was a fellow in training at Washington University. This is one of the first large studies to show why it's important to treat quickly. So we took these patients that came into the emergency room or the coronary care unit at Barnes, and we randomized them to medical treatment or going to the catheterization lab immediately to see what's going on and do they need treatment. And what we found is that the patients that went to the cath lab and were treated within about 2 hours, that their survival was markedly improved, and it's very obvious there's a time-dependent drop-off. So the longer it is till the patient gets to the procedure room, the lower the positive outcomes. So that's why we call this a time-critical diagnosis. If you have these symptoms, when you come to our emergency room, which is a certified chest pain center, we have a very important protocol. You get an EKG within 10 minutes. You get seen by the provider, the nurse, within the first 5 to 10 minutes. If there's any suspicion of acute heart attack going on, we don't have the capacity to do catheterization here, but we have strong relationships with Mercy and with BJC hospitals to get you there quickly. We notify the team at those institutions, and they'll be ready for you when you arrive to get to the catheterization room and get treated, and the goal is 90 minutes. We go for 60, but the goal of treatment, kind of the big inflection point here, is right around an hour and a half. You can see this big drop-off starts occurring. So we like to get you to the other facility for your procedure within about 90 minutes. Wait, go back. Just a couple quick points. Looking at intervention, PCI is what we call when we open up the blood vessels of the heart. So if patients have a heart attack, which is called a ST elevation MI, the mortality in women is higher than men, okay? The mortality for women dying from a heart attack is 15% in the first year for women and 9% for men. Okay, dying in the first 5 years is after your first 4 years, for your first heart attack is 21% in women, 15% for men. So we got to get to the emergency room quicker, we have to start treatment, and we have to be as aggressive with your treatment plan and your follow-up plan once we make the diagnosis. The later presentation, good deal. Later presentation to the clinic or the hospital is associated with delayed diagnosis, and without a diagnosis, you have delayed treatment. So quickly get here. We'd rather have you come in, check you out, and say, look, we think things are okay, than have you not come in. It's always better to come in and be evaluated in the emergency department, primarily, or walk in or our office, or call our office, and we can start your plan of action. Next slide. Okay, next slide. Oh, that's a double of the other one. Okay. The other issue is after treatment, after, let's say you've had a heart attack and we do a stent or bypass surgery, cardiac rehab undoubtedly has been shown to improve long-term survival and long-term improvement in functional care and decreased events in the future. So we have a great cardiac rehab program here for 30 days. All insurances cover it after a cardiac event, so that's important. And women are well known to be underrepresented in cardiac rehab because they get less referral and less completion of treatments. Okay, the referral basis is our problem. Okay, we as providers have to make sure, and we're getting better at standard orders, if someone has an acute event, they automatically get a referral to cardiac rehab. So we're working on that from our end, as not just here, but everywhere, on referring everyone to cardiac rehab. The other issue, though, is women who do go to cardiac rehab have a tendency to drop out. You know, I don't have the time for it. I have other things. I have to get back to work. No one's getting my kids to school, et cetera, et cetera. And that's true for moms as well as grandmas, because grandmas are really important in care of our families. But when they complete the programs, it's been well shown that women experience the greatest reduction and benefit from cardiac rehab. So our goal is to refer more to cardiac rehab, complete cardiac rehab, and continue your follow-up care with us or your other providers in clinic. So this is what the problem is. The problem is irregularity of the blood vessels. This is the aorta, which is the large tube. Oh, I didn't bring our toys down from our office. Oh well, we have a bunch of toys that we'll go, little models we'll go over with you when you come visit us in clinic. But this is an example of an autopsy specimen of an individual who was 18 years old who died in a motor vehicle accident. So 18-year-old healthy guy unfortunately died in a motor vehicle accident. So this is the inside. This is looking like at the inside of the blood vessel. And you can see at 18 years old, you already have these ridges starting. Okay, this is atherosclerosis or irregularity of the blood vessels. So even in an asymptomatic 18-year-old healthy individual, we already see these irregularities. And if you look closely, what you'll see is most of the irregularities are by these little branch blood vessels, because the blood flow changes as it turns and goes into these blood vessels. And this is a lot of times where we have problems occur, because over time, as these thickenings and irregularities grow, what we do is we get a blood clot on top of this, and that blocks off the artery, and that causes a heart attack or a stroke downstream, because blood can't get from here to the heart. It can't get from here to the brain, and that's what results in a heart attack or stroke. So blood clots on top of irregular blood vessels are the most common cause of heart attacks and strokes in all of our people that we see. So this is a quick example of what a heart attack is. This is what a heart looks like. Remember, the heart is like the engine of your car or your truck. You have to get gas to your truck to make it work. Okay, just like you need blood, the blood vessels are the tubes that carry blood to the heart tissue. And we have three main, Morgan and I do this 5 times a day. If this is your heart and these are the blood vessels, we have 3 main blood vessels. One goes to the middle, one goes to the left, and one goes to the right. Then they each give off branches like a tree. Okay, so if we have this blood vessel in the middle, which is one of the main ones, if it gets a blood clot here, you can see this area. I apologize, we didn't bring our little heart models. This area after the blood clot isn't going to get enough blood flow. So that's why we want to open it up with medicine and a stent and a procedure to stretch the blood vessel open and to reperfuse or get more blood flow to that area of the heart or the brain. So that's what a heart attack, but it's a similar situation in the brain. This is an example of someone who unfortunately died of a stroke, and the blood vessel to this area of the brain broke, and they bled into their brain. This is what's called an aortic dissection, which is a tear of the main blood vessel that leaves the heart out to the body. And the blood vessel tears for the same reason. You get clot or irregularity in the blood vessel, it breaks off, and then a clot occurs, and it blocks it off, so you can't get any blood vessel, any blood up to your brain or down to your belly, your stomach, or your legs because of this clot. And if this occurs quickly and it's not diagnosed, we have a 50% mortality within the first 2 hours if this occurs in the blood vessel going up out of the heart. So we want to diagnose this quickly and get you into treatment, but that can't occur unless you're here at the hospital. You can't make this diagnosis at home. Next slide. So just some other pictures quickly. This is a kind of a tissue specimen of a blood vessel. This, what we call lumen, this is the hole where the blood goes. And as you can see over time, it's been thickened. It's been blocked off from being this size. When it's normally there, we have atherosclerotic plaque, which is cholesterol and other materials develop, and it pushes the blood vessel open space smaller and smaller. And on an X-ray, you've probably heard of an angiogram or catheterization test. This would be the X-ray equivalent of this. What we see is this would be a normal blood vessel, but then it starts to taper down to about half the size of what it should be. And then if it breaks and we get a blood clot on top of that, you can see this haziness here. This is an example of a blood clot inside of an already narrow blood vessel. And this person was having a heart attack that we can go in, stretch it with a balloon, and then put a stent in there, which is a metal mesh, which keeps it open. Next slide. One point I wanted to emphasize is that the blood vessels in the body are all connected. They're all the same kind of blood vessels. So if someone has an issue in the heart, we always look at the circulation to the brain and the circulation to the abdomen and the legs. One common request we have for a consultation is an individual is going to be seeing the surgeons because they have some blockages in the blood vessels of their neck and they're undergoing surgery. So the surgeon asks us, what is the patient's risk for surgery? They're not asking us, what is the risk of the operation? They know that better than we do. They know what the operative risk. What they want to know is the patient's heart strong enough to undergo it? Because if you have a blockage in either of these areas, in the brain area, in the heart area, or in the leg area, there's a 1/3 chance, a 33% chance you have blockages in the other blood vessels. And we need to say, does something need to be done first, particularly with the heart, to make you safe to undergo the operation to fix the circulation to your brain? And this is another cartoon to just show a blockage, a blood clot, on top of an irregular blood vessel. And this would be in the heart, and this would be in the brain, and this is what we want to prevent. Medication will stabilize these plaques. Aspirin will help blood clots forming on these clots, and this is why we treat different medications which work differently to improve your situation. Okay, so when we see a patient, we go through a 3-step process, which has to be in order. The first thing we have to do is evaluate you. We have to take a history. The most important part, without a doubt, of our evaluation is your history and your physical exam to see what is going on in your life. What risk factors do you have, which are situations which put you at risk for heart disease? Have you had a previous event? Have you had a first-degree relative, a parent, brothers, sisters, or children with a heart event? Because we know that that puts you at higher risk. So without a doubt, a thorough history and exam is important. Next. And then okay, so once we make a thorough evaluation, then we could talk about your assessment. What tests need to be done to rule in or rule out a problem? So first we do your history and physical, then we do the assessment, and then we can say, based on our assessment, after doing tests, using computer-based risk calculators and some testing, then we can come up with a treatment plan. You won't come into our office and most providers' offices, and the first thing they do is they start giving you medicine without doing any testing. because that's just gunshot medicine. That's not individualized care. So we go through this process very methodically to come to a treatment plan that's individualized for each patient, because every patient is different. And we want to make sure you have the best, safest treatment plan for you. One really important point in women that we have to take as part of our history is your obstetrical history. You might think at age 65, well, why does it matter? Well, this is why it matters. When you were pregnant, if you had gestational diabetes, if you had preeclampsia, which is high blood pressure at the end or just after your delivery, or if you have what we call polycystic ovary disease, which is a syndrome the gynecologists see commonly, which is a combination of ovarian dysfunction, issues of generally overweight, glucose intolerance, which is prediabetes, that will put you at over 50%. Well, this is the ratio, in other words, how common it is for you. So you're 1.6 times higher risk for heart disease in the future if you've had one of these during your pregnancy. And the gynecologists are very good at screening for this. Gynecologists do more glucose tolerance tests, as a lot of our younger females know, during pregnancy as a standard part of your evaluation. And it might not show that you have diabetes in the pregnancy, but if it's on the higher end, it tells us, A, you're at higher risk for the pregnancy itself, but more importantly, it tells us in 10 or 20 years when you get referred to us as your adult providers that you're gonna be at higher risk. So we hone in on that as a very important, what we call risk factor. So what are the risk factors that we look at? Well, one thing that's really important, without a doubt, is smoking. And smoking is very interesting, okay? If you've been smoking for a long time and you stop smoking, no matter how long you've been a smoker, within 6 to 12 months, your risk for a heart attack or stroke gets down to the general population as a non-smoker. Now that might not seem intuitive, but what that tells us is smoking is an acute toxin. It's an acute effect on the cardiovascular system. Okay, now other issues and medical conditions are related to how much you smoke totally. Cancers in particular, esophageal cancer, stomach cancer, colon cancer, breast cancer are all related to how much you smoke. So the questions we ask in the heart clinic is, when did you stop smoking, okay? And occasional smoking doesn't help the situation. When have you stopped smoking? And we mark that time point in your chart. And then if you've been a smoker for a long time, we make sure your primary care knows that so they could follow up for screening for those other long-term cancer-related issues. So smoking is a big thing. It's the #1 reason people come back after a heart attack or stroke or surgery, is they keep on smoking. If we stop that, it really will improve your outcome. Abnormal cholesterol pattern, we'll talk about that. High LDL, or we call LDL the lousy cholesterol. We like to get that number down because we know that'll strengthen the heart. And HDL, which is the helper cholesterol, that's the good one. So we look at a cholesterol panel, and it's a very simple test that we do once or twice a year in the clinic. We check your blood pressure. Blood pressure is particularly important in women because it's the highest risk factor for stroke in women, especially women who are postmenopausal. So blood pressure measurement and control. And stress modification. I can't overemphasize the importance of stress in all of our lives, but it seems to be particularly relevant in women. So we have to address it, define it, and come to a team approach with your healthcare providers, with your primary care provider, the nurse practitioners who see you, the mental health providers, to work with you on stress management. There's not much you can do about your age. It is what it is. Men are men, women are women. Okay, a family history of heart disease. What this is important is in first-degree relatives who have had a heart problem under the age of 55 who are non-smokers. So that's an important discussion. Okay, when we say, Papa died at age 50 of a heart attack, And, that's awful. Of course it's awful. But what we want to know is, is he smoking 2 packs of Lucky Strikes a day? Because in that generation, which is the generation of our parents and our grandparents, smoking was ubiquitous and common. And smoking was the most common risk factor far and away in that generation. So when we hear that mama or papa died, and if they were smokers, that in and of itself gives us less confidence to evaluate you. But if papa, or particularly mama, passed away at age 50 with a heart attack and she wasn't a smoker, that really makes us believe there may be some genetic predisposition, and we kind of look at you and evaluate you in a slightly different pattern. Okay, so we did that. Now, when we evaluate you, there's kind of 2 big groups of people. People that have already had a heart attack or stroke, or they've had a bypass surgery or something like that, and they come to see us afterwards. What can I do now? So we call that secondary prevention. You've already had an event. How do we prevent a second episode? Okay? The groups, so anybody that's had a heart attack, stroke, intervention, they've had blockages fixed in their legs, blockages fixed in their brain, or they've had a stroke, they have eye disease that the eye doctor tells us there's blockages, kidney conditions, but the big one that I'll get into is diabetes. When you have diabetes, especially diabetes requiring insulin, for a female, it is the equivalent of having a previous heart attack in someone who is not a diabetic. And I'll show you the data, which is very compelling. Diabetes in a female is an incredibly strong risk factor that we screen for and treat aggressively. Okay, we kind of went through this. Next. All right, so this tells us when we have risk factors, they start adding up. This is if a woman has high blood pressure, the risk is about double. If they have diabetes alone without high blood pressure, the risk is double from an individual without risk factors. But then you start adding high blood pressure and diabetes, you can see the risk goes up 3 times. So it's multiplicative. So multiple risk factors are much more concerning. I mean, any risk factor is concerning, but when we have multiple risk factors, we see the risk goes up. And look at this individual who is a female with high cholesterol levels, hypertension, and diabetes. Look at this risk compared to the individual without risk factors. It's up about 20 times. So that's why screening, you can't tell this without a clinical evaluation in the office or without blood tests, is really, really important. Okay, next slide. So normal blood pressures, just quickly, are 120/80. That's our goal of blood pressure. And it's both. Notice I use the word and. You want the top number, which is really the biggest predictor of stroke, and then the bottom number, which is important for peripheral vascular disease. So we take your blood pressure every time you go into an office, right? You go to the dentist, you go to the foot doctor, whatever. We always take your pressure. What we call elevated blood pressure, or borderline elevated blood pressure, is 120 to 129 on the top number, or if it's greater than 80 on the bottom number. Okay, either or tells us we have to have a higher index of suspicion that this is coming up, and we'll have you come back. We'll talk to you about getting your blood pressure monitored at home by a machine. And also, just out of interest, the health department, we have a grant at the health department to give out free blood pressure machines. Okay, you go to the health department, which is over on Bowser Drive behind Casey, and you just go in there and tell them you want to be evaluated for high blood pressure. The nurses have a protocol. They teach you how to use the machine, and as long as you call in each week for 4 weeks with your blood pressure, you're allowed to keep it. And that saves you $50 to $100. And we got that government from the grant to do that because high blood pressure is so important. We want to use blood pressure machines that go around the upper arm, not the wrist ones and not the finger ones, because there's a lot of irregularity in those. The most consistent are the blood pressure machines at home and what we call an automatic blood pressure machine that goes around your arm. Stage 1, or early or mild to moderate hypertension, is 130 to 140 on the top number, or 80 to 90. And then when your blood pressure is over 140, or the top number is over 90, that's significant hypertension that needs aggressive treatment with lifestyle measures, exercise, dietary interventions, and generally medication at this point. Next slide. Okay, looking at cholesterol, we're going to switch to cholesterol now. This is one of the large studies that showed us many years ago, 30 years ago, that cholesterol is important. So they looked at all cholesterol levels in, I think, 100,000 patients who had heart disease and who didn't. So what you can see, this line here is people who didn't have known heart disease. And mind you, the definition 30 years ago for having heart disease was probably weaker. So these curves are probably more splayed now if we repeated it in 2025. And these are individuals who had an event, a heart attack, a stroke, and we measured their cholesterol levels. So you can see, one, the cholesterol levels of the heart disease patients are higher than the non-heart disease patients, because their mean was about 180 versus 160 or so. But the other thing that's important is people who came in with a heart attack, a third of the patients had a cholesterol level that at that point was considered normal. Back in the 1990s, we considered a total cholesterol of under 160 as normal. Now, we've changed those guidelines, and I'll review the new guidelines, but that's why we dropped the guidelines, because we were missing these whole people. Oh, your cholesterol is fine. We don't have to do anything about it. But now we know that treatment with lifestyle measures primarily, and the benefit of additional medications can strengthen the blood vessels and prevent the heart attack. So the cutoff now for total cholesterol is 130 to 150, and then we treat aggressively. So we definitely need to be under 160. We're treating at 130 right now. The LDL, the bad cholesterol, if it's over 100, we want it less than 100. If it's over 100 in somebody who hasn't had a previous event, that's when we start talking aggressive lifestyle measures, see the dietitian, and then come back and see us for a follow-up visit, follow-up blood test a month or two later, and then we could discuss if you would benefit from medication. Triglycerides are also something else we measure. Triglycerides are another fat component in the blood that primarily relates to carbohydrates. It's very diet dependent, and this is really a marker for diabetes. So anyone who has high triglycerides, we always screen for diabetes, because triglycerides are made from carbohydrates. You eat bread, crackers, cookies, scones, whatever you eat, and then the body breaks it down, and the fat gets repackaged from the fat in the butter and the scone and such into the cholesterol particles in the body that can cause irregularity and high bad cholesterol levels. So that's why we look at diet as a really important factor, and we always screen for diabetes in those groups. People that are considered high risk, who are the high risk female groups? If we do a risk calculator, which is something we do on our phone or you can do on your phone, it'll ask you questions like, what's your age? What's your cholesterol level? Do you smoke? Do you have high blood pressure? Have you had a previous event? And if you hit the button and the computer works it out, and it tells you on the bottom of the page, this is a 10-year risk calculation. It will tell you have a 10-year risk of 3% of a heart attack, 8%, 10%. Over 7.5% is what we consider abnormal, and greater than 10% 10-year risk is what we recommend, and the medical community recommends starting treatment with medication in addition to lifestyle. So a 10-year risk for a heart attack or stroke is the cut point for medical intervention in addition to lifestyle measures, where it's required for everyone. Next slide. Statin medications are kind of the mainstay of therapy. They decrease how cholesterol is repackaged from the liver. There's many different available. A not uncommon side effect, I'm not going to say common, not uncommon side effect are muscle aches, and that has to do with how the medications get into your muscles and out of your muscles. There's a way of adjusting that. One thing that's really important, as we get older, we always have more muscle aches anyway. So when we start a medicine, it's easy to say, oh, it's from the medicine. not uncommonly it is, but most of the time it's not. So we have ways of adjusting the dosing, adjusting the time of day you take it. Do you take it with meals? Do you take it 2 or 3 times a week as opposed to every day? And we have all kinds of ways because we deal with this every day in clinic. It's a common concern, but it's important to take your medications. Because as we've seen in a lot of studies, especially in somewhat at high risk, that greater than 10% risk, if you take a statin medication, no matter what your cholesterol level is, you have a 25% less chance of having a heart attack or stroke in 5 years. So by putting the pill in your mouth, it's not just the cholesterol it's lowering, it's strengthening those blood vessels, preventing them from cracking and getting that blood clot. And that's probably the main benefit of the medicine. It's probably more how it affects the biology of that irregular blood vessel than it is actually lowering cholesterol. Cholesterol is what we measure, but it's not where the action is in the body. The action is how the cholesterol medications, the statins, affect the blood vessels. That's why it's important. So even taking a low-dose cholesterol pill 2 or 3 times a week will undoubtedly prevent you from having a higher chance of a heart attack or stroke if you are prone to that. Let's talk about diabetes quickly. Let's go to the next slide. Okay, so this is, I mentioned this earlier, this is a study of over 20,000 patients, and there's 2 groups of people. This group, in the red-orange group, these are people who have not had a previous heart attack. Okay, so this group and this group, okay? This group has not had a previous heart attack. These are non-diabetics. These are diabetics who have had a previous heart attack, these 2 groups. So let's compare. What you can see is that the individuals who are not diabetic but have had a previous heart attack, your chance of having a subsequent heart attack in 5 years is 20%. It's 1 out of 5. Okay, that's what it is. That's kind of the baseline information. Now let's look at our diabetic friends. If you are a diabetic requiring insulin and you have not had a previous heart attack, your chance of having a heart attack in 5 years is 20%. It's equivalent to the non-diabetic who's already had a heart attack. So we call this a risk equivalent. So just by having insulin requiring diabetes, we get much more aggressive in your treatment because we're treating you like you've had a previous heart attack. Now look at our friends who are diabetes and have had a heart attack. They have almost a 50% chance of having another heart attack in the next 5 years. So we're really, really aggressive about their follow-up and their treatment plan and helping them stay on their program to bring this number down. Next slide. And these are this is just emphasizing the importance of diabetes and heart disease. So this group, just very quickly, these are the people without diabetes, without a previous heart attack. And this is death, right? Percent survival. So these are death graphs. This is the individual who is diabetes without a previous heart attack. This is the individual who doesn't have diabetes but had a previous heart attack. And this is the combination. This is the patient who has diabetes and has had a heart attack. So in 5 years, if we go up, assuming my pointer still works, okay, it's right at 75%. So 75% of the patients are alive, which means 25% have died in this 5-year follow-up. So it's really important to diagnose and treat. Okay, looking at diabetes, one of the most common things we're concerned about is obesity. We call this, when we look at somebody's body, that's called anthropomorphous. So kind of the male usually has central obesity, tummy obesity, no butt, and that's kind of the male thing. The female thing we call the pear-shaped body, which is that the stomach and waist is generally okay, but most of the weight is lower. And what we found is that the more central obesity there is, the higher risk of diabetes and glucose-related problems. So for a man, go back. For a man, the cutoff is 40 inches. If their belt, it's a simple question, what's your belt size? Okay, if it's 40 or higher, that's too big. For a female, it's a 35 or higher because you're measuring at the waist, not at the hips. Okay, so that's an important measurement. Simple measurement. What's your waist size? Okay, obesity and diabetes goes together. That's why aggressive weight loss, especially these new medicines we have, Ozempic and Mounjaro, have not only had people lose weight, their diabetes controls and decreases heart risk, because it decreases the initiation of diabetes by weight loss. The cutoff for the diagnosis of weight loss, of diabetes, is impaired glucose tolerance. When we start getting worried, it's a sugar of 100, or if you have 126 on 2 subsequent random fasting blood tests, that gives us the diagnosis of diabetes, or a hemoglobin A1C, which is a long-term blood sugar measurement of 6.5. The other test, which we don't do much in adult medicine, but the OBGYNs are great at, is the glucose tolerance test, where they take a baseline blood sugar level, you drink this disgusting stuff, and you wait an hour, 2, and then you get blood sugar measurements. So if your blood sugar goes up by 40 points over your baseline, or greater than 140 altogether, that tells us you have impaired glucose tolerance and a very high risk for gestational diabetes. So eating, seeing how your body responds to food is a very important way that we measure diabetes. That's why sometimes we'll do random blood sugars. This slide emphasizes that once we make the diagnosis of diabetes, at time 0, people have had diabetes for up to 5 or 10 years. So we're making the diagnosis too late because we're not screening people early. If we could shift this curve over here, we could diagnose earlier, and just like I said in the earlier slides, we can treat earlier. We're not picking people up till here. So that's why screening is important, and the earlier we screen, that's why we do blood tests when you start coming in for your 35 or 40-year-old physical exams, because we want to move this curve to the left. We want to treat you, or diagnose, and then possibly treat you earlier. Next slide. Smoking. Smoking is an acute toxin on the cardiovascular heart, of the heart system. We talked about that in general. When you look at, there are a lot of studies done, particularly Iowa had a bunch of heart studies done. When they banned smoking in theaters and bowling alleys on Friday nights on the weekend, heart attack rates went down by 50%. Why? Because you go with your friends bowling, you eat, you drink, you smoke a half a pack or a pack of cigarettes, at the bowling alley. And what they found, our cardiology friends who do procedures were all upset because they weren't getting the patients. Why? Because they weren't having heart attacks. Okay? So that's why all this public smoking ban has really gone into effect. It really affects not only acute problems, but long-term effects of smoking. And as I mentioned, after stopping 6 to 12 months, you really improve your health. Your cancer risk is about how much you smoke totally. And just functionally, you'll feel better. Your smell and taste will come back. The morning smoker's cough will go away. You breathe easier. And then you can exercise more because you have more capacity in your lungs to do activities. So stopping smoking is really important. This little cartoon says, "Oh, honey, I'm so proud of you. You stopped smoking for a week." Well, poor guy's in the hospital, right? And this doctor tells him, "Well, I'm really glad you switched to light cigarettes, but I hate to inform you, you have a light cancer," right? So we have to take a smoking history. We have to discuss this with you. We're not harping, but what we're doing is really trying to let you know, to empower you to help in your health care. Next slide. Weight management. As we talked about, dieting, even losing 10 or 15 pounds will make a big difference. Whenever I put this slide up, everybody pulls out their little pad and their calculator, because this is the formula from the Metropolitan Life Tables, which tells you what should your weight be. So it's, for a female, it's 105 pounds for your first 5 feet, 60 inches, then 5 pounds per inch. Okay, so 135, let's say you're 5'6", that's 6 inches higher, 6 times 5 is 30, so about 135, and if you give or take 10%, I would say under 140 to 145. So 140 to 145 pounds would be where we like to see an individual, a female patient of ours, within that weight range, okay? Another quick way to say, well, what can I do? Well, to maintain your weight, okay, you eat 10 to 12 calories per pound. Okay, so if you weigh 150 pounds, you eat 1,500 to 1,800 calories a day. That's a nice, quick and dirty way of figuring it out. Well, doc, how much do I have to lose, how much do I have to cut back on my diet to lose weight? The answer is 600 calories, 600 calories a day, because that comes up to 4,200 calories in a week, which is 1 pound of fat. So if you're eating 2,000 calories a day and drop to a 1,500 calorie diet, you'll lose a pound a week of fat. No doubt about it. So that's kind of the quick and dirty way of looking at it. And our dietitians are very helpful. This is from that old movie, Super Size It, and the guy on the trial is blaming poor Mr. McDonald, Ronald McDonald over there. He forced me to eat and supersize it. And I think the fast food company, because a lot of us eat a third of our meals from fast food, have really taken advantage of that, making changes. For example, changing the kind of fat they use to even make the French fries. That makes a big difference, right? And they could do it on the back end and you wouldn't know the difference. So that's why nutrition counseling is really important. Okay.
Hello everyone, the 10 o'clock presentations are about to start. We'll have Mona Lisa Touch in the Education Conference Room with Joseph Charlo, MD, and Mary Crucilius, nurse practitioner. And then in the fitness area, we'll have a bar workout with Debbie Raymer. So get it going. They're up next. Thank you.
Okay, healthy food selections. We always refer you to a dietitian. Next slide. Just keep on going. Okay. So physical activity, it's really important to walk 150 minutes a week. Okay, that's 30 minutes 5 times a week with moderate activity. If you do intense activity, like working hard treadmill to the point where you lose, you're sweating and everything, if you do 75 minutes a week, that's actually what we call a good exercise program. Okay, adding strength and muscle endurance, and any kind of physical activity is important. Park your car farther away from the parking lot. Use steps when you can. Walk whenever you can. If you can walk 5,000 to 10,000 steps a day, that'll be great. Get yourself a little pedometer at the Dollar General. So this little guy is not so little. This guy is walking, sort of. He's walking his dog on the treadmill. Well, that doesn't help very much. Okay, this is, I wanted to emphasize and advertise our bicycle trip that we do. We have a health fair activity in the fall where we have a bike-a-thon, and it helps not only raise money for cancer, but it's also great activity. I did this with my son a couple years ago. I kind of made it to the 15-mile mark. That was a miracle and a half. Got my little doggy here. And my son got all the way to the 30-mile marker. But we do that every year. You'll see advertisements. It helps save money and make money for the cancer department, but it's really important to get yourself out in group activities. It's fun. You'll get a t-shirt, and we all encourage you, when you register for this, you go on our general mailing list, so you'll get information, and you'll see information in the paper about our bike or walking activity. Stress management is really important. Stress has been shown independently in women to be more of an important risk factor than in men, but of course it's important with anyone. Next slide. I did show this with my staff and they thought it was kind of funny, so I kind of put it up for you. So this is a study that looks at marital stress, okay? So we looked at heart disease in women in the survey said they were satisfied in their marriage, unmarried women, and women who were, had low satisfaction scores in their marriage. Okay, well, I don't know. So basically, that's of course kind of an open question, but the bottom line is that the more stress, especially in your home life, you see, the greater risk. This is for heart problems and this is for stroke. So it's important to address your stress, talk to your providers about it. We have a lot of resources for counseling if necessary, but stress management is as important as blood pressure, smoking, and cholesterol control. So in summary, what are our goals of therapy? We want to get your blood sugar down to normal, control blood pressure, no smoking, cholesterol management, exercise, get yourself out walking, and stress management. Okay, so now We've gone from a blank canvas to a full canvas, which is a beautiful painted picture, and hopefully we were able to give you some information on how we could develop an individual portrait for you of your health situation and help you stay healthy over the years. I'll be happy to take 1 to 2 questions. I'm sorry we're a little on the late side. We have our office cards here, and Morgan and I will be happy to meet with you on an individual basis or get the information to your providers to help supplement your healthcare needs. Does anybody have any questions? Yes?
Does secondhand smoke make a difference?
Secondhand smoke is more important for that long-term cancer risk than for heart disease. Yeah, it probably accentuates acute heart disease, but it's nothing like smoking yourself. But secondhand smoke, without a doubt, has been shown to be beneficial. Avoiding secondhand smoke for long-related cancers, esophageal cancer, breast cancer, and other intestinal cancers. Okay, so this talk, since we recorded it, we'll have it on our website. You can call us. I also encourage you to get on our patient portal. We'll have options for that. I'm sure we have a booth for that upstairs, right, Mary? To register for the portal. We really encourage that for communication. Then you can ask us questions. You can, just all kinds of things with the portal. It's very, we've worked it up over the years to make it very user-friendly. You can request your appointments. You can request refill requests. And we will get back to you, I promise, within 24 hours with an answer to your question. Thank you very much. Please enjoy the day. Ask a lot of questions, and we're always available. We'll be roaming around, and I appreciate your attention. Have a good day.